So the key factors in all this to have a good healthcare system with universal coverage and a certain quality of medicine is the regulatory power of the public authority. And government can regulate all aspects of healthcare, even if it's not a national health service. It can fix the number of medical students, including how many doctors should be specialized for heart disease or cancer disease or whatever. It could decide, this is difficult because the doctors don't like it, but the government theoretically can do it by law and say, well, you have to exercise in that or that region because there are doctors lacking in that region. Or if you want to be a doctor, an independent doctor, after your studies, you have to work the first 6 or 7 years somewhere in the countryside. So government can do all this, depends on what are the values at the basis and if public opinion will follow. It can fix the salaries or honoraria of doctors and all the other health professionals already, because many of these professionals are in public employment, but it can also fix tariffs for private doctors. If I see my private family doctor here in France, it costs 25 euros. That's the tariff of the government. The doctor can't take more. Well, he can take more, but then he needs to have a special authorization and a special regime and all sorts of special things. It's regulated. The government can fix the prices for pharmaceutical products. Very often it's the health insurance, the social health insurance, who will negotiate with doctors on tariffs and with the pharmaceutical industry for medicine prices, because they reimburse it, this money. It's not the people who pay it. So it's the insurance. But in cases sometimes when you have a regulation a little bit softer, the government will try to negotiate every year with the pharmaceutical industry to see if there are products which we may have for less money, or if we accept to reimburse very new products with a high price, very innovative cancer treatment, for instance, then will you lower prices for this and this and that, because you do it for many years and the production should be cheaper. So the government comes in to negotiate very often, because finally it's public money who pays this. So the government can do lots of things. It can also fix the care basket. It can decide, his have to respect. With the health insurances have to respect. Okay, the care basket is the care you are normally entitled to. If there's innovative care, for instance, we have not yet so much security about new genetic treatment or something like this, then there's a security question and there's a price question. Is it worth to pay so much money for this treatment for just a few patients, or just to give a few patients some more months to live? Is it worth it? Then doctors say, yeah, it's also for research. We will know more. And afterwards we benefit more from it. Because we are collecting, clinical experiences and so on. So in all these discussions, the government will be somewhere present. It can decide the level of contributions and even the premiums to private health insurances if the private health insurance has a monopoly for covering the total population, as it is the case now in the Netherlands and in Switzerland. Then the government will come and regulate how much money they can take from these people. And it can define, the government, who are the free beneficiaries, who will be health insured without paying any contribution because people are too poor, don't have much money. So who can go just walk into a hospital or a doctor's office. In health insurance systems, generally, these people need to be affiliated to a health insurance. And the problem is, who is going to pay the contribution? Sometimes the government will pay it, will send the money to the health insurance corresponding to these people. Sometimes it will be, France has found a very good answer. They take the money for these poor people, about 10% of the population is freely insured. They don't pay any contribution and they have the same care basket than I have, or even more in it. they get dental care free, which I have to pay out of pocket, because otherwise I couldn't afford it. So the government started paying the contribution for this, for these people. And then it started taking a special tax from the private complementary voluntary health insurance to say, well, you should contribute also to cover these poor people. And they accepted. Say, okay, we are nice. We are also for solidarity. We will pay you. And they agreed about 1% on their business turnover per year. They will give into this common fund to pay to the public health insurance, the equivalent of the contributions these poor people don't pay. And now, 10 years later, it's about 6 or 7%, this tax, and the total charge for free affiliation of all this, about 10, 11% of the population, is paid by the private complementary health insurances. So this is a very complicated architecture, where the French, they are very good in making people who have a little bit more pay for all those who have a little bit less. They call this solidarity. So the health insurance in France, for those who don't have enough money to pay their own contribution, it's paid, it's under threshold of income, and it's paid by the supplementary private health insurance, which covers, you know, the rest of the population. Every French person has such an insurance. Okay. Now, the theoretical summary of the major healthcare system types, all the things I said already are summarized here. The type of system, national health service, social health insurance, private health insurance, the values and principles. Here it is equal access to services by everyone. The funding comes from the public budget, from the general taxes. The provision is mainly by public providers. Oh, sorry. Public hospitals or public doctors. And the governance is state planning and state control very tight. So they have control over their budget. That's why their healthcare system costs less, but they have waiting lists. Social health insurance, there will be equal, the value will be equal access to services among the members of that special fund, because they are organized generally by professions. So there's a fund for engineers, there's a fund for, I don't know, for train drivers and pilots and so on, and for industry branches. And they have to fix up their budget, and they can play a little bit on the care basket and on the contributions within the limit fixed by the government. So the funding is, as I said, social health insurance contribution according to income or to salary. The service provision is either by public providers or private providers, but mainly in non-for-profit setups. That is changing now a little bit. The municipalities, for instance, in several countries, among them Germany, sold their little hospitals, which they owned since 100 years, and they didn't have enough money to modernize them and so on. And it was found out that small hospitals are not really so safe, so we should have bigger ones. So they sold them to private investors who transformed them into something for which there's a big business. For instance, they do only one type of operations, and then they have very specialized doctors, and they contract them with the social health insurance for the price, but they get a lot of activity because public hospitals are not built anymore because the money is not there. So a lot of private investment is entering now, and it's not always not for profit, or they transform it into all people's residency, which is a big market. So there are a little bit things changing. Governance and regulation, well, as I said, collective bargaining of corporate actors, the doctors on the one side, the health insurance bodies on the other side, and growing state regulation. Private health insurance, access according to your ability to pay premiums. Higher premiums, you get a better care basket, better clinics, better doctors. Private insurance premiums are according to the risk. The best client would be somebody who's just 20 years old, has never been ill, and who doesn't move very much, doesn't have risk for accidents. That's the best client. Private for-profit providers. So everything will be somehow for profit making, even if there's government regulation. Clinics will be private, or people's house will be private. There will always be sort of, calculation for profit. And there will be a lot of competition between all these private actors, competition which the state can limit. We talked a lot in our science about regulated competition and regulated privatization. That means we privatize certain things, but there will be regulation around it. Or we allow a lot of competition, but it will not be just for money making. There will be something like quality and user satisfaction and things like this will come into the basket. Now here's summing it up. You will see the different health types again. I put together in a statistics the funding of the current health expenditure for 2019. I generally took the year 19 in order to avoid the COVID incidents. So we have seen the percentage of GDP of health expenditure. We have seen per capita. Here it's PPP dollars, because the statistic comes from the OECD, which works with dollars. The other one came from European Commission. They work with euros. So this is just a recall. We have seen these things. But I put together here 3 countries, because you have it also in your readings: Germany, France, and Sweden. And then the 2 poorest countries in our statistics, Bulgaria and Romania. So you see here the difference between per capita spending. It varies between 6,500 PPP dollars and 1,900, let's say. In Bulgaria, that's 3 times more. Now, the interesting thing, which you haven't seen yet, is where does this money come from? How much is public spending in this current health expenditure? Current health expenditure means all the expenditure of the healthcare system, which is sort of day after day. It does not include investment. If you build a new hospital, that's not in. It's just the care and the salaries for the people who work there and the pharmaceutical products and all this. So the public spending would be either the social health insurance or government. Now, and here you have the private health insurance, a percentage of this current health expenditure, which will be paid by private health insurance, if there is one, and out of pocket, what people will pay out of their pocket. Okay, now let's look at these figures. In Germany, 78% of the current health expenditure is paid by the social health insurance. So this is the proof that this is a social health insurance type, because most of the money is covered by these social health insurances. The government gives 6.5. So the total public coverage in spending terms, it's 84.6% of the current health expenditure. So that's quite a lot. So private health insurance is little. If I have time, I will say a few words about it, but maybe tomorrow. And out of pocket will be an average something like 12 to 13% of this current expenditure. Now the 6.5 will be some government subsidies, maybe for special programs like looking after children, or for special rare illness, or for the poor people's coverage, the contributions they don't pay, the government will pay, maybe pay it through the health insurance. Now in France, you have more or less the same profile, except you have 7%, which is covered by private health insurance. Because the French system has never been free when the health insurance was founded, the actually one after the Second World War, there was a money problem. They didn't have enough money, and they said, well, the people should pay 30% and 70% should be the health insurance of the expenditure. And then different levels were established according to all sorts of criteria. So reimbursement was never 100%. And that's why private complementary health insurance exists. They existed before, but it's only health insurance. There was no other one. And they were kept alive with this complementary part. So all the French people have two health insurances, including me. A public one, the major health insurance, which pays the 78% of the expenditure, and a private health insurance, which will pay the rest, which they don't reimburse. And that is about, in average, 7% of the current total expenditure. But out of pocket will still be 9.3%. So you see, France here is very proud that they have the smallest out of pocket in the whole of Europe. But they never tell you that you have to pay twice the contribution, because into this health insurance, the private complementary one, you have to pay contribution. And mine takes a solidarity principle. They take it in percentage of income. So that's rather expensive for what they give back. So they don't count family members, for instance. If I had 5 children and an ill husband, they would all be insured for the same money than I pay for myself. So it's according to need. So this is a little bit true. We don't have much out-of-pocket payment, but we should consider that we pay much more contribution than other Europeans because we pay twice. Okay, Sweden, you see they don't have any social health insurance. The government pays everything because they have a national health service. So the government pays about 85% of the current health expenditure. And they have very few private health insurances, very little, it's just 1% of the expenditure. And they have about 14% of out-of-pocket payments today. So it grew. There were days when there was zero here, and in Germany there was zero here. And the cost control reforms at health care became more and more expensive, led to the introduction of small sums of out-of-pocket payments. But if you sum it all up, it's about 10% in most countries now. Okay, now let's look at the poor countries. Bulgaria, they have a social health insurance system, which pays about half of the expenditure. Government pays something like 10%. So you see they have about nearly 40% out-of-pocket payments, which is a lot, considering notably that salaries are low in Bulgaria. Romania, they have the lowest percentage of GDP for healthcare and the lowest per capita spending. And you see the government makes a bigger effort than in Bulgaria. They have little private health insurance and people pay about 20% out of their pocket. Now, if you come to the average for the 27 countries in Europe who are completely differently organized in their healthcare systems, and they have different levels of being rich or poor as a country and as a healthcare system, you have average GDP spending will be nearly 10%, with 3,700 PPP dollars per person every year. So that means a family of 4 will have a health expenditure on average about 12,000 PPP dollars. But salaries are something like 2,500. So practically half of the year, what these people would earn, it will be spent for their health expenditure in average. And it's other people who will pay this. This means universal access. So if you want a country with universal access, you have to be prepared to pay for it. You pay for a lot of other people. Or you have a bad care system for all the people. This was more or less the common situation in communist countries. It was not very expensive and it was all free, but it was not very good. And only special people could go to very good clinics. So we don't want such a system. So if you want universal access for everybody, quality access and equal treatment, you will have to have a lot of people who pay a lot more than they do actually, because they will pay for all those who pay less and spend more because they have the children or because they're very ill and so on. That's in the logic of a socialized healthcare system. So the average is about half is social health insurance And the third is government spending. So we can conclude here that the Bismarckian system with the social health insurance is still the majority in the European Union today, at least in terms of the coverage of the current expenditure. They pay more than half. And they have about 20% in average of out-of-pocket payments, because in these Eastern countries, they are very high, because these countries don't have yet a very mature healthcare system because of their economic basis, and maybe also because they just fail to organize it. This is what is said partly in the reading you have, and I agree with it. Now, if you look at OCDE average, because that's more countries, all sorts of other countries in it, it's the percentage of spending is a little bit less than in Europe. So see already Europe spends more of GDP. No, sorry, I take back what I said. First of all, I have to say the OECD includes the US healthcare system, and that's a very particular system. It costs a lot of money and the results are not very good, but in the average, this will show. So the US has spent on healthcare 17% of its total riches of the GDP. It's equivalent to 11,000 PPP dollars for each resident in the US. Every baby and every grandmother counted. That's an enormous lot of money. And with all this money, they are not able to cover the total population. They don't have a complete coverage as we have in Europe. So this is, in my opinion, the worst healthcare system you can have. Extremely expensive and absolutely unequal. And, you know, this is when you make healthcare as half a business market. You know, the health insurances are private in America. And not even President Obama got his plan through for universal healthcare. You have still about 12% of the people in America who have no insurance at all, or are very underinsured because they have options. They can choose. I want to be insured just for this and just for that, which you can't do in Europe normally. So you're insured once for all, and you pay once for this. And in America, you can choose all sorts of things. So people, they underinsure themselves, and then they have a big health drama, and they can't pay. I have read several times that personal bankruptcy in America was mainly due to medical bills. People have to declare, sell their house, have to declare bankruptcy totally because they can't pay their medical bill because it's so expensive, and they don't have a proper health insurance. So nobody goes bankrupt in Europe because of medical bills, because we have a health insurance compulsorily. We can't choose, we have to have it. And if we are too poor, then we don't pay the contribution until we earn more money, and then we start paying contribution. But we will be insured. We will not pay the hospital, at least not completely. We will pay maybe this part, but poor people don't pay it. At least not in Germany, France, and so on. For the Eastern countries, probably they will have to. Okay, now I put India because I found a few statistics of the OECD, which included India, and look at the figures. 3.6 of GDP in India is spent on healthcare. That's the lowest figure of all the countries which were in the statistic. And that was the 36 OCDE countries plus 6 or 7 others. So 40 or 44 countries. India was the least spender. And in PPS dollars, it means 257 in 2019. Before COVID, per capita spending on each Indian, which is really nothing. The government foots about 33% of this expenditure, probably because of all these public health programs you have in India for rural areas and so on. And 11% is employer private health insurances. People who have a good employment, they will have a health insurance, a proper one like in Europe with their employer. And the most of the money will be paid out of pocket. So you see, there's a lot of things to revise in India, probably, yeah? If you see these statistics. OECD includes countries like Chile, all sorts of Brazil, all sorts of countries who are not really particularly rich. So, and India turned out to be, with this booming economy, to be the least health spender of all. I think it's a good idea to run this master, bring some new ideas. Okay, the European Union has a powerful role to tools to bring the member states into upgrading the healthcare system. Those who are not very good, that they learn to be better. So they make benchmarking on all sorts of situations. Let me give some examples. We have benchmarkings in Europe on survival rates 5 years after a heart attack or after cancer, all the different types of it, cancer, survival rates for all sorts of illnesses. And then you can compare countries and say, and we had a case from Britain. Britain had survival data about maybe 15 years ago for cancer, which was similar to below Turkey. There was none in Europe who had so poor results. So Britain was very much ashamed when these statistics came up. We didn't know before. It was the European Union who organized this benchmarking. And in very, very quick time, it was, I think, Tony Blair in those days, Britain set up proper cancer services and the survival rates went up very quickly because it was so shameful. So you have, you don't have a power at the European Union to intervene with the national healthcare systems, but they have all sorts of soft power, and benchmarking is one of the very important ones. So just a little example about the French report I was reading. Out of per capita spending in France, we know we spend much more than European countries on hospital care, much more on pharmaceuticals, because we have in France something against generics. Doctors don't prescribe much generics. So we are still at the end of the European list for use of generic medicine. And doctors have total prescription freedom. They prescribe what they think is good for the patient, and they don't care much about the money, which is a good thing. But there's also economically, it's a little bit difficult, because many people have lots of medicine in their bathroom, and it's all to be thrown away afterwards because there's too much prescription. And we always have complete packages. When you need 3 pills only, they give you the package with 40 pills, even if it's very expensive, because they don't have packages for 3 pills. So there are all these things. And this comes out when you do comparing with European countries. If you look only in your country, you think this is normal and you can't change it. But you see all the other countries do it differently, then you can have new ideas.